Oh, there we go. There.
All I had to do was try to click on that title afterwards. I always advance whatever window is active.
I see.
This is. Everything's. Yes. Yeah.
Hello? Testing. Is it working? Please continue to talk amongst yourselves. This is actually the start of the talk.
Yeah, I haven't. I assume. Yeah. Oh, there it is.
I know, they still like partials like other people are like. Yeah. And then.
Yeah.
This year I decided. I did vacation.
I mean, I'm just standing there. So perfect day. My privilege.
Yeah, I think go to work. My apologies for
Thank you, Dave.
Welcome, everyone. Good afternoon. Thank you so much for coming out on this very sunny Thursday afternoon. I want to start off today by acknowledging, of course, that we are meeting today on the ancestral territory of the Halkomelem-speaking Stalo people who have occupied these lands since time immemorial. And it's important UFE recognizes and honors the contribution that Indigenous people have made and should continue to make to our community. And it's important always to take time to reflect about that as we engage with issues that are important, issues like health and pandemic response, which are important, I think, to settler communities and Indigenous communities alike, maybe in different ways. I want to start off today by handing over the mic to our Political Science Student Association. Armand and Lauren are going to make a very quick announcement.
Hello, everyone. We're from the Political Science Students Association, and we were just going to make a quick announcement that afterwards there's going to be a social at Brown's. All students are invited. We hope to see you guys there to continue the party, and just right after, yeah, just right head over there, and yeah, we'll see you there. We better see you guys there. All right.
Thank you. Thanks so much, and thanks again to the PSSA for organizing these fantastic after-party events. You can keep the discussion going, obviously, in a more laid-back format. All right, so to introduce our guest today, we have our department head, Dr. Edward Akufo, our fearless leader. So let's welcome him with a big round of applause.
No one always refers to me as a fearless leader. I'm not sure whether I'm very scary, but I'm not, right? Yes. Yes. Thank you very much, everyone, for coming, and it's a real pleasure, to have you here, and especially for for Politalk, where we get to talk about issues that really affect our society, and on topical issues that really generate lots of interest and lots of debates. Now, to say a few words about Politalk, the Politalk, lecture and roundtable series is a platform for engaging in topical issues, pushing the boundaries of, ideas, creating public awareness, and sustaining active minds that are conscious of political, cultural, socioeconomic, and socioeconomic issues in our community and the world at large. Now, today's lecture is titled, as you can see here, Pandemic, Preparedness and Response, Health Security or Health Equity in a Divided, World. I think that although we are beginning to see the end of, the COVID-19, pandemic, I think we all agree that we are witnessing a very challenging, global, order at this moment, where we see old allies, becoming almost like, if you will, very disruptive and all that. And that raises big, questions about global governance, especially relating to, health security. We will have the privilege of hearing from an esteemed scholar on health, policy, very well known across Canada, and her work is also, known across, the globe. Now, in the spirit of enhancing the quality of academic debate through diversity of thought, permit me to quote these words by the ULB president, Dr. Joanne McLean. Dr. McLean argues that engaging in different viewpoints and having our beliefs challenged is a fundamental aspect of university life. We must strive to preserve the vitality of our academic community and foster academic freedom while grounding our discussions in care and mutual respect. This is a challenging but necessary undertaking, and I believe, this is Dr. McLean, saying, I believe that together we can promote healthy dialogue at ULV. Now, in that light, I hope that we will share our ideas, we'll share our thoughts, here, guided by the principles of mutual respect and care for each other. Now, I'll introduce, our speaker. Our speaker today is Dr. Suzanne Hindmarch, who is an associate professor in the Department of Political Science at the University of New Brunswick. She studies the politics of infectious disease response, focusing on the origins, impacts, and efficacy of the policy and political strategies through which infectious disease is addressed at global, national, and subnational levels. In particular, Dr. Hindmarch examines the conditions under which the health of equity-deserving groups is or is not advanced in infectious disease response, especially in the context of global health security. She also studies the interface of global and domestic infectious disease governance, asking why global infectious disease response strategies are adapted, or resisted domestically, and how states advance domestic priorities via global health governance mechanisms. Dr. Hindmarch holds a PhD in political science from the University of Toronto, and MA in international development studies from Dalhousie University, and a BA in political science from my alma mater, University of Alberta. Prior to her academic career, she worked in community-based AIDS organizations and in the Public Health Agency of Canada. So this is an academic who also is a technocrat, having worked, on the field. And it's a real pleasure to have you here, Dr. Hindmarch. So please, we are ready to hear you in speak to us. Please, let's receive her with a round of applause.
Thank you, and thank you, Dr. Akupo, for that very kind and generous introduction. And I feel under some pressure knowing that this talk is what stands between you and the after party hosted by your student organization. So I'll try not to be too much of a barrier between you and fun. So I want to again thank Professor Akupo for inviting me to give this talk, and I also want to thank Natasha Tvete, did I get that right? For all of the logistics and organizational work. And thank you to all of you for being here. And I also would like to acknowledge that I am a guest on these lands, the unceded territories of the Stovo peoples. And I am also a guest who arrives here from the University of New Brunswick as someone who is a guest on another unceded territory. And those are the unceded and unsurrendered territories of the Mi'kmaq, Wolastoqey, and Passamaquoddy peoples. Now, land acknowledgement is a lot of things. It's an invitation for us to be together in respectful community with each other, with the people whose lands these are, with the land itself. But it also names a problem, and that problem is the ongoing relations of settler colonialism. So in that sense, a land acknowledgement is not itself a solution to the problem that it names. So it is also an invitation for those of us who are settlers on these lands to reflect on what more and what else is needed, especially if we take seriously the observation of two scholars named Tuck and Yang, who have offered this important insight that decolonization is not a metaphor. It is a set of actual real world practices that require structural change and also a transformation of relations, including power relations at multiple levels. So my talk today is about health security and health equity in pandemic preparedness and response. But there are some core tensions between those two things, health equity and health security, that at the deepest level are about relations. They're about how we relate to each other, and how we live in community with others. So I hope that what I have to say today, although it is not directly about decolonization or indigeneity, although there are some allusions to it, which you'll note in the talk, that this might also offer one way into thinking about what might be required to achieve equity in a world that remains deeply and perhaps increasingly divided, including through the relations of settler colonialism that land acknowledgements draw our attention to and call on us to address. So I said this talk is about health equity and health security in pandemic response. So let's start. Let's see if I can make this go. Nope. There we go. How many old people does it take to set up a newfangled technology? So let's start by setting the scene at the very end of 2019, when the WHO began to receive reports of a new respiratory virus in China. And then it seemed that almost overnight, the world was in lockdown, in the grips of a global pandemic. So that by the spring of 2020, and for the next year after that, we would see headlines like this. And we would see images like these of images and headlines alike, all telling a similar story of a world caught off guard, a world underprepared, overwhelmed, with mass graves, these desperately overworked healthcare providers, intubated and seriously ill patients, people queuing for hours to receive emergency food and other supports. And in even the wealthiest high-income states, places like Canada, Italy, the United States, we saw some pretty significant health systems failures. And especially we saw a failure to protect the most vulnerable among us. In Canada, many of you may remember that one of the most visible of those failures was in long-term care facilities. And we saw that headline on the previous slide. Of all the OECD countries, Canada had the highest COVID mortality rates among seniors in long-term care facilities. But we also saw many other health equity failures. And what I've got on this slide are just a couple of examples from Canada and globally. So in Canada, COVID death rates were disproportionately high among socioeconomically disadvantaged populations. So people living in poverty, who in Canada are also often Indigenous, racialized, First Nations, Inuit, Métis, living at the intersection of a lot of other structural disadvantages, and who are more likely to be people who are working in low-paid, essential services positions. So that's the Canadian example. And then this map, which is maybe a little bit difficult to interpret, indicates inequitable distribution of vaccines. So we saw inequitable distribution of a lot of resources, masks, oxygen, personal protective equipment, with lower income states in the global south losing out. And what we're looking at here is the percentage of the total population now that has been vaccinated with at least one dose of a COVID vaccine. And this dates back to the middle of the pandemic. So by December of 2020, Canada had 429 COVID vaccines. Now that is enough to vaccinate every Canadian 11 times over. We had that in December 2020, while lower income countries were struggling to obtain any vaccines for their populations. And this resulted in racialized north-south inequities in vaccine coverage that the World Health Organization Director General denounced as apartheid, the vaccine apartheid. And what you can see on this map is that that continues. So the African continent in particular still has a majority of the population who have not received at least one dose. So the darkest countries here on this slide have achieved almost, in some cases up to 90 or even higher percentage of the total population, down to the lowest light blue, where 4% of the population, or thereabouts in some cases, has been vaccinated. So I want to be clear, the domestic and the global response to COVID was not just about failures. It was not only a story of failure of pandemic preparedness and response. There were successes too, including the speed with which we got vaccines, and in Canada, the speed with which we got those vaccines into people's bodies. But COVID and the COVID response was also a product of and produced inequities, divisions, and systems failures that persist today. And there were a lot of reasons for these failures. But today, what I want to focus on is one in particular, and that is the ways that pandemic preparedness and response has been shaped by this fundamental tension between health security and health equity. And I'll define and explain those terms in a couple of slides. So to understand how these tensions and gaps between health equity and health security contributed to some of these COVID failures, and especially to equity failures in terms of which populations had highest mortality rates or death rates and lowest access to vaccines, we need to first look back at the health security measures and health equity initiatives that were in place before COVID, domestically and globally. And then we need to consider the post-COVID responses and revisions to pandemic preparedness and response systems that are underway now. So turning to the first part of this, the looking backwards, a lot of the popular press coverage of COVID, and for a lot of us, our own lived experience of COVID, was that it was this sudden, unexpected health emergency. And we experienced the response largely as this short-term crisis response that had a pretty defined start date with lockdowns and social distancing measures, and then it had an end date when we kind of returned back to normal and were able to congregate as we are now. But a global pandemic was not unexpected for people in the global health world. We'd had several earlier outbreaks of respiratory illnesses that were very similar to COVID in terms of transmission, in terms of their symptoms, in terms of their treatment. Those included severe acute respiratory syndrome, or SARS, in 2002, H1N1, swine flu, in 2009, Middle East respiratory syndrome, or MERS, in 2012. So both SARS and MERS were coronaviruses, just like COVID, and a lot of, actually all of these were confirmed or suspected cases of zoonotic disease. So these are diseases of animal origin that can what's called spill over, cross the species barrier so that they're transmitted from animals to people and then person to person. And this is an important point, and it's one that I'm going to come back to. There were also Ebola and Zika outbreaks, which I haven't put on this slide because they weren't respiratory illnesses, but they were also outbreaks that tested global health security responses. So the point here is that we had several dry runs at pandemic response generally, and at response to respiratory disease outbreaks specifically. we had several opportunities to implement and refine pandemic preparedness frameworks with these smaller scale outbreaks. And in the wake of every one of these outbreaks, we had recommendations about actions that should be taken to strengthen health systems, about actions that should be taken to strengthen disease surveillance, about what research should be undertaken, about what animal vectors and viruses were of greatest concern. And so that's what the image on this slide is communicating. So these are all the previous times by the WHO in 2003, 15, 16, 17, 18, and by all of these academic researchers who published articles in very highly ranked, globally accessible journals, medical and scientific journals, of all the times that we were warned before. And to some extent, those warnings were heeded. So in Canada, for example, these warnings that we need to support and enhance health security led to the creation of the Public Health Agency. That was created in 2004, right after the SARS outbreak. And it was created largely, although not exclusively, to help improve our federal capacity to respond to infectious disease outbreaks, to do things like improve FPT, or federal, provincial, territorial coordination, to collect data and to do health surveillance, and also to strengthen Canada's ability to participate in global health emergency systems and surveillance and response. So we had that domestically. And then at the global level, we had what's called the IHR, the International Health Regulations. So these are globally the most important global health governance framework when it comes to global health security. So these came into force in 2007. And these are the only legally binding international agreement signed by 196 states to monitor, report, and respond to public health emergencies of international concern. So this agreement, the International Health Regulations, requires states to do things like monitoring and to report to the WHO any infectious diseases with pandemic potential. So diseases that have the potential to spread rapidly across borders, to have a significant public health impact, including through a high mortality rate, and a significant impact on international travel and trade, and that therefore require a coordinated global response. And so the key points here are that, first of all, we did have health security systems in place before COVID. So this didn't just come out of nowhere with no existing response systems present that should have been able to respond to it. So domestically in Canada and globally through the IHR, long before COVID, we had these systems in place specifically to support pandemic preparedness and response. Second is that these health security structures are largely focused on monitoring, scanning domestically and globally, on data collection, things like health surveillance and reporting, and having measures in place that kick in if and when there's a disease outbreak. So that includes things like surge capacity, having stockpiled supplies, also a lot of defensive measures that are focused on containment. So plans for restricting movement through border control measures, through curfews, closing public places where diseases might spread. And so therefore, three, on paper, in Canada and globally, even with just these health security systems and structures in place, we should have been better prepared for the COVID pandemic than we in fact were. So why weren't we? In part because in Canada and globally, these health security measures were marked by some significant weaknesses. So here on this slide, I'm highlighting three. There are others as well. And I'm going to say a little bit about two of them and then focus for the rest of the talk on the third one. So first, and for those of you who are political science students, this should not be surprising, one of the enduring limitations is that health security systems, like any global governance mechanisms, like any federal or provincial policies, politics, programs, these have been under-resourced and they have faced some enduring political challenges. Domestically, the Public Health Agency was given a mandate to basically help the provinces and force or encourage the provinces to work more closely together and communicate and coordinate on monitoring and surveillance. So that mandate to just strengthen federal, provincial, territorial, Indigenous coordination and data sharing has always faced some pretty significant political constraints, the constraints of federalism for anyone who's a Canadian politics student, and the division of powers, especially when it comes to health. So in some ways, that particular health security mandate was always an impossible task. And there were also a lot of organizational bureaucratic politics that I could talk about more if anyone is interested. Globally, the IHR set out a reporting and a response framework, but a lot of work has to happen for countries to be able to monitor and report on the diseases of interest to the IHR. So those health security systems that are needed to support international health regulation obligations and requirements require lab facilities, requires testing, requires highly trained health experts, response plans for potential emergencies, regular access to reliable refrigeration, communications technologies, electricity. That's a lot to ask. To have countrywide systems in place that can support that monitoring and surveillance in a lot of lower income global south states where a lot of the public has fairly limited access to basic healthcare, especially once we get into more rural and remote areas. And healthcare systems are already understaffed, underfunded, and have more limited capacity to address far more common health issues than potential hypothetical infectious disease outbreaks. And the other really significant political challenge, and this is a big problem in global health governance, is that the IHR did not have any financing mechanisms, and they still don't have any financing mechanisms. So there's no mechanism to support lower income states to put in place these costly additional health security measures. So in practice, a lot of states have either been unable or they've been unwilling to invest in what would be required to do the monitoring and surveillance that the IHR required. There are also, and I'll come back to this point later, these really big enduring challenges relating to sovereignty and relating to the limited capacity and authority that the World Health Organization, like any actor in the UN system, limited capacity to compel sovereign states to act, or to compel sovereign states to be transparent and honest and open in sharing data, and also to be equitable and fair in sharing resources once a health emergency has been declared. So that's one. Second is that these systems have been very anthropocentric. And by that, I mean that they have tended to pay attention to human health, but not so much to animal health, to environmental health. So human health security, pandemic preparedness, detection, and alert systems tend not to pay attention to infectious disease outbreaks in animals until and unless there's a spillover and those diseases begin to affect people. And especially until there are variants that not only infect people, but infect people in a way that people can then go on to transmit the disease to other people. And so this limits our ability to detect and contain animal outbreaks before they become a really significant impact on human health. And this is important because most new and emerging infectious diseases are zoonotic. They're of animal origin. And it also means that even really severe pandemics in non-human animals can be under-prioritized and under-recognized as significant health emergencies. And we're seeing the consequences of this now with the current pandemic that we're in the middle of, and that is H5N1, the avian influenza, highly pathogenic avian influenza epidemic, which again, or pandemic, we can talk about more in Q&A if there's interest. Third, and this is what I'm going to focus on for the rest of the talk, and I promise I'm moving the slides on soon, is that there have been these enduring tensions between health security and health equity, and a relative lack of attention to equity within health security systems. So one tension is that even within what are supposed to be these fixed permanent systems that the Public Health Agency operates, within all of the systems that are required to make the IHR work, that it's been really difficult to maintain adequate attention and funding and preparedness for hypothetical potential health security and disease threats, when there are always, for states, more immediate actual threats, not just health threats, but also often more traditional national security threats that seem a lot more urgent and immediate. So there's this recurring pattern, which we see on this slide, of warnings of an acute emergency response, and then this organizational forgetting. There's a health emergency, there's urgent exceptional response, and then we breathe a sigh of relief and we go back to normal and we forget the warnings of the WHO and scholars. And the second related tension or gap is that within health security responses, there's been an enduring lack of attention to health equity. So I've said that most pandemic preparedness measures have generally focused on things like monitoring, things like surveillance, surge capacity for emergency response. And those have generally occurred separately from longer term, non-emergency, normal politics, programs and strategies to address regular health issues, including the promotion of health equity. So health equity, in essence, is about ensuring that all people, everywhere, have the ability to attain the highest possible standard of health. And this requires addressing systemic and structural forms of disadvantage. So it requires what are called upstream proactive disease prevention efforts to address the bigger conditions, the socio-political, the economic conditions that can help facilitate infectious disease outbreaks specifically, and that more generally result in higher rates of poor health among structurally disadvantaged populations. And these are known in the public health world as the social determinants of health. So these are the conditions in which people are born, live, work, and age. And these influence the health of populations. And they do this by influencing our individual health behaviors, but also by influencing our health in ways that are beyond our individual control. So you'll see a lot of different lists and ways of visualizing the social determinants of health. I like this one because it shows the ways that social determinants of health create or contribute to various forms of vulnerability that can then impact health outcomes. And I want to emphasize too that this shows inequity. So the ways that social determinants can produce inequity and poor health outcomes, but these can also be protective. So various forms of privilege can also positively affect her. So the social determinants of health and the considerations that we need to keep in mind when we're thinking about health equity include things like the social and built environment, things like our housing and our workplace conditions. Do we have grocery stores? Do we have active play space in our neighborhoods? Do we have green space? Do we have water? Do we have power? Do we have other infrastructure? How safe are we, or how safe do we feel in our communities? They include things like income, socioeconomic status, education, food security or insecurity, or geographic location, and all of those interact with each other. And they also include things like gender, sexuality, racialization. And all of these in turn are shaped by unequal race, gender, class, and other power relations, including the power relations of settler colonialism. So that the social determinants of health are also really the political determinants of health. So the way that these all interact in really complex ways produces inequitable health outcomes for structurally marginalized populations. So people who are more likely to experience poorer mental and physical health, also to experience more significant barriers in accessing healthcare, all because of consequences and dynamics that are noted in speech bubbles on this slide and the gray text on this slide. So for example, depending on what your physical and built environment is like, you might experience homelessness and housing instability, but you also just might experience really poor, substandard, overcrowded, overpriced housing. So overcrowded housing in which respiratory disease can spread more quickly, overpriced housing that then means you have less money for things like really healthy, nutritious food. And you probably have higher levels of stress because of that. So all of these are things that impact our health. And so this brings me to the point or the central argument that is that there's this problem or tension in health security frameworks. And that is that the health security of populations and the health security of states. So our ability to withstand or our ability to effectively respond to infectious disease outbreaks is deeply shaped by social determinants of health. It is deeply shaped by health equity and inequity. So health inequity can facilitate infectious disease outbreaks by producing, as I said, the socioeconomic conditions, for example, that are conducive to disease spread. Living in overcrowded or poorly ventilated housing, shelters, urban slums, places where hand washing or hygiene might be more difficult because there's not adequate water and sanitation. Places where people might, because they're living in poverty, already have all sorts of other underlying health conditions arising from poor nutrition, or lack of access to clean water, or to primary health care. And infectious diseases also then impact the social determinants of health in ways that can exacerbate longer-term health inequities within and across states. So we saw this during COVID. The very richest, the Elon Musks and the Jeff Bezoses of the world, got a lot richer during COVID. The poor got poorer. So at the individual and community level, there were people who lost jobs, including because of the disruption in global supply chains. So we can think, for example, about the closure of entire sectors at the production end of global supply chains, which are also often located in lower income global south states. So if we think about Bangladesh, for example, which is a place where a lot of the world's fast fashion is produced, a workforce of mainly young women was laid off when all of those factories were closed because their orders from fast fashion big brands in the global north dried up overnight. So when people are unemployed, they can lose housing, no longer afford healthy, adequate food, school fees. All of that has long-term impacts on the social determinants of health. And during COVID, the extent to which governments could provide stopgap measures to mitigate those impacts really varied significantly by country, especially by country income level. So higher income countries were better able to provide a lot of support measures than lower income countries. And at the global level, this added up to produce a reversal in what had been trends of declining global poverty rates. So before COVID, if you looked at a line graph of rates of extreme poverty in the world, that line was going down, and it was going down steadily year after year. We hit COVID, and all of a sudden that line started rising again. So the proportion of people living in extreme poverty rose during COVID. It is now slowly declining again, but more slowly. And wealth inequality within and across states has grown. So these dynamics inside states, but also globally, risk creating this very negative feedback loop in which you've got post-pandemic societies where people maybe, entire communities, entire states, as well as individuals, may be more vulnerable to future infectious disease outbreaks because of the impact on their health and the social determinants of health that they experienced because of COVID. And at a population level, and also a level of individuals, the worse health inequities are going into a pandemic, the more severe the impact of that pandemic is going to be, especially on the most vulnerable. So what is the point here? The point is you'd think then that proactively strengthening the health of populations by reducing health inequities, by addressing the social determinants of health, should also be a really important cornerstone of pandemic preparedness and response. Because the more equitable in terms of health and social determinants of health your society is before a pandemic, the better positioned you are to withstand it. And the more extreme the inequalities within your society before a pandemic, the more extreme the inequitable health outcomes of that pandemic are going to be. So you'd think this should be a cornerstone of pandemic preparedness and of health security systems and structures, but it's not. Now, obviously, there have been and there continue to be a lot of efforts domestically and globally to address health equity, to address all of these social determinants of health. In Canada, we can think about all sorts of welfare state measures and targeted programming. We can think about the Sustainable Development Goals globally. We can think about all of the work of UNDP, UNAIDS, UN Women, a lot of other organizations in the UN system. But those have proceeded on pretty separate tracks from health security responses and health security structures and activities. There are different policy frameworks, there are different agreements and regulations, there are different lead actors, and there's very little interaction a lot of the time between the two. So the health security measures through which pandemic preparedness has been operationalized have very rarely included health equity or social determinants of health considerations. For example, if we think about the international health regulations, those are those legally binding requirements to monitor, to report, to then respond to infectious disease outbreaks. Those have no requirement for states to pay attention to gender, for example. So there is no built-in requirement for states or for the World Health Organization to consider the gendered impact of outbreaks or the gendered impact of pandemic responses on, for example, domestic violence, or on access to reproductive health care, or access to gender-affirming care, or even to collect and report gender disaggregated data. And although when you look at the global tables where these decisions are being made, there's regional representation from each of the WHO geographic regions. But there haven't been requirements to include civil society or to include representatives of equity deserving groups at the tables where some of these emergency health response or pandemic response decisions are being made. So those are largely technical and biomedical tables. And the same is true in Canada. So our health security surveillance systems, including the ones that collected COVID data, were not designed to collect, and they didn't collect, data that was disaggregated by gender or data that was disaggregated by racialization or indigeneity. And our pandemic preparedness tables, our rapid response, research response tables, all of the other COVID-19 decision-making tables that were initially designed and initially struck based on health security frameworks had been developed for the most part without health equity lenses. So that meant those tables were mainly populated by scientific and technical experts, and largely by experts in Canada's largest cities, who were not primarily members of or representatives of equity deserving groups. So decisions about lockdowns, about social distancing, about curfews, about restrictions on movement were made in most cases without representatives of those equity deserving groups, racialized, indigenous, homeless populations, for example. And this is important because these are populations that have a really long history of being over-policed, of being underprotected, and experiencing discriminatory treatment by the police, but also by health services providers, in ways that contribute to what is often a very well-founded lack of trust in healthcare providers and health messaging. And that meant that those interventions, when they were first rolled out, were rolled out without taking into consideration whether there might be more severe impacts and specific mitigation or support strategies that might be needed for some of those structurally marginalized populations, or even thinking about what might be culturally competent or culturally appropriate messaging to use. And because of not having disaggregated data about gender, about race, about racism, a lot of those decisions were and still are being made without a lot of evidence and without a lot of data that can be used to support evidence-based targeted interventions that are taking in mind or being mindful of equity considerations. Now, obviously, when you're in the middle of a pandemic, that is not the time to be integrating equity and social determinants of health into surveillance and data collection systems. That's not the time to be recoding all of your databases so that you're taking into account all of the genders and racialization and indigenous identities. The middle of a pandemic is not the time to be integrating an intersectional gender lens into the international health regulations. But my point is that those considerations weren't built into those health security systems and pandemic preparedness measures before a pandemic. And that a failure to pay attention to health equity in those health security and emergency response systems has long-run consequences that can impact the social determinants of health. And so this brings us to the question, I'll have to pull up my phone to advance the slide instead of the clicker to advance the slide. That brings us to the question, if these equity considerations were inadequately incorporated into health security pandemic preparedness systems before the pandemic, how are we doing now? Have we learned this time? So let's turn now to post-COVID. So I put post here in quotation marks, first to acknowledge that COVID is still here. People are still dying in Canada and globally because of COVID. We've transitioned to living with the virus, but it is still life-threatening for people who are immunocompromised, for people who have underlying or chronic health conditions. So it is still life-altering for the people who care for those who are living with compromised immune systems. It is still life-altering for the people who are continuing to live with long COVID. So not everyone everywhere is equally post-COVID. But we certainly have moved out of that acute emergency phase of everything being in lockdown and having to stand at least 5 feet apart from each other and sing happy birthday while we're washing our hands to make sure that we're washing for a long enough period of time, and all of the things that we remember from the height of the pandemic. So here I'm going to focus just on the global level because that's where the most important initiatives are happening. So the short TLDR here is there's been some progress, but there are still some enduring challenges. So there have been some amendments to the international health regulations. There's been language added calling for the WHO to facilitate timely, equitable access to health products in pandemic emergencies. So this is good. We do now have some recognition of health equity in the international health regulations. This is important, and I don't mean to downplay that, because if any of you have studied global governance and negotiations at the global level, getting even to non-binding language in global agreements is an accomplishment. But there is still no legally binding mechanism that would require states, and especially those high-income states, to actually share health resources more equitably in a future pandemic. And even that aspirational language is about sharing resources in a pandemic, not in those sort of upstream proactive supports. We also now have a pandemic fund. And this is also, again, quite a significant accomplishment because this fund now exists specifically to fund pandemic preparedness and response measures in lower income states, with a focus on funding surveillance, laboratory systems, and health workforces. So some of those things that I said at the beginning of the talk are challenges for lower income states to be able to meet their IHR regulations. And this pandemic fund has an explicit commitment to One Health, to the recognition that human, animal, and environmental health is interlinked and interconnected. And this fund has supported projects to strengthen and to integrate animal and human health surveillance systems. So this might partly address some of those issues around anthropocentric or human-focused surveillance systems that don't pay adequate attention to animal health outbreaks. And there's also, in this new fund, there's explicit attention to health equity and to gender equality in funding projects. So this is also positive progress. So this might be evidence of not just a change in discourse, a change in norms, but actual change in funding with material dollars and cents attached. So Canada's committed $37 million to this fund. The United States committed $700 million under Biden, but it's doubtful that that commitment is going to be honored under the current administration. And this is one of the enduring challenges. And that enduring challenge is that this fund depends on donors in the states, and state priorities can and do shift, sometimes pretty dramatically, which we certainly are seeing with our neighbors to the south right now. So donors committed funds in the immediate wake of the pandemic, but it remains to be seen if they're going to continue committing funds over time. So if you remember what I said earlier about having exceptional urgent attention and funding, but then the difficulty in maintaining sustained support over time. So there was a lot of global momentum that led to the pandemic fund being resourced. We'll see how long that actually lasts. There was also a lot of global momentum around calls for a new pandemic agreement. And there were calls for this new agreement before these other two initiatives got up and running. So what people had in mind at the time was something like the Paris Agreement for pandemics. Enthusiasm for that has slowed quite a bit, in part because we do now have these other mechanisms that have been put in place, but also in part because in these negotiations, which are ongoing right now, there's a lot of resistance on the part of high-income states to support any sort of binding mechanism to support technology transfer and to support sharing health products and benefits. So more substantive movement towards equitably distributing global resources is still something that high and low income states are really, really deeply divided on, which again goes back to some of those really enduring political challenges and political divisions. And even in the new pandemic fund, the emphasis is still on a lot of these fairly narrow pandemic preparedness strategies, things like surveillance, labs, and investments in health workforces. Now, those do also contribute to public health. Those are really, really important, especially for countries that don't have them or that have limited high capacity labs or health workforces. But those upstream initiatives to address the social determinants of health, all those things that I showed you on the previous slide, those forces that much more deeply shape health equity and vulnerability are still largely unaddressed. And all of these new health security and pandemic preparedness and response efforts are for pandemics, strategies to prepare for a future pandemic. But there are a lot of other global health challenges, and it's actually chronic and non-communicable diseases that contribute the greatest share to the global health burden. So not only are the broader social determinants of health and non-communicable disease interventions absent from health security measures, but there's also a risk that if aid money is being redirected to pandemic preparedness into some of these new measures, or if it's being withdrawn altogether, which again, we're seeing in the case of USAID right now, the United States Development Agency that funds a lot of, including, but not limited to, health and development initiatives overseas. There may actually be less funding available for some of those upstream social determinants of health initiatives. And then finally, I alluded at the beginning of this talk to these core tensions between health security and health equity. And I'd like to conclude, as I move towards wrapping up, by reflecting on them, especially the new salience that these tensions take on in this geopolitical moment, where we're seeing some pretty significant shifts in world order. So a shift to a multipolar world, which is about how power is distributed across states, but also a shift in how states are using that power. And when some people are suggesting that we're seeing the end of the so-called liberal world order. So this is an order which, with all its injustices, still has some predictability and consistency in the norms and the rules that structured the way that states interacted and that structured multilaterals, participation in things like the UN and the IHR and the Pandemic Fund. So to be clear, those norms and rules and relations were sometimes consistently unfair and hypocritical, but there was, or at least there seemed to be, some stability from some points of view, depending on whose vantage point you're looking at the world from. But with this retreat from multilateralism, especially but not exclusively by the United States, we're seeing this global populist far-right turn. We're seeing this transition towards what are sometimes quite explicitly xenophobic, racist, hostile interstate relations, and increasingly a turn towards states prioritizing some pretty narrow national security interests. This retreat, this turning inward in what is being experienced by many as this increasingly hostile, unpredictable, multipolar world. So these interstate relations can be compatible with domestic health security measures of a sort. But these are relations that are fundamentally incompatible with health equity, and they are fatal to health equity domestically and globally. Obviously, at a global level, even a health security preparedness system, even something like the IHR, the Pandemic Fund, a pandemic agreement, if it comes to pass, depend on multilaterals. It depends on international cooperation, sustained financial commitments, a sustained commitment to cooperation and data sharing, and even these are under pretty serious threat right now. But at the domestic level, health security can still be compatible with antagonistic or with pretty isolationist national security policies and practices. Because health security can also really easily slide into, as I said at the beginning of the talk, defensive and containment focused measures. So things like border controls, things like quarantine, things that are often a fundamentally defensive reaction against. A focus on protecting and enclosing a healthy, threatened us from a disease that threatens our security, our lives. A disease that might be viral, microbial, airborne, waterborne, but also often a disease that is understood or imagined to be carried by infected others, people and places who are not us, who are a threat to us. And those threatening others could cross those protective borders and boundaries. So in this sense, those domestic security measures, things like border controls, building walls, xenophobic and anti-immigrant policies and sentiments. If we saw it during COVID, if we think about some of the anti-Asian sentiment that we saw in some quarters, including from Trump, and things like the vaccine hoarding that we saw from high-income states, including Canada. These are all compatible with a really narrowly understood sovereign national health security interest. So again, health security in some form could survive a retreat from multilateralism. Some health security responses to future pandemics would still be possible. But they would likely be possible in ways that work against health equity. In contrast, health equity is necessarily fundamentally about ensuring that everyone has access to the supports that they need to maintain individual and collective health and well-being. So it's about proactively strengthening the social determinants of health. It's about protecting the right to health and all of the other human rights that we need to be able to exercise the right to health. And this requires a much more expansive understanding of community. It requires a commitment to solidaristic relations, relations that transcend borders between states, borders between populations. And that sense of solidarity, that sense of usness, is fundamentally incompatible with hyper-nationalist, socially and fiscally conservative movements that have little or no interest in addressing equity at home or abroad, and any sort of equity, not just health equity. So health equity measures within states and also at the global level, within and beyond pandemic preparedness, are really not ones that are very compatible with, and not ones that could easily survive a really sustained retreat from multilateralism, or from global cooperation, or from investments in the social determinants of health. So in sum, and in closing, there's this underlying tension between health equity and health security that, as I said at the beginning of this talk, at the deepest level is about how we relate to one another. It's about how we relate to and live in community with other people, other places, other human and more than human life, and about how tightly or how expansively we understand the boundaries and borders that divide us from one another, that mark us off from them, or that connect us through relations of care, of solidarity, of mutual obligation, of interdependence. So we've heard often, diseases don't respect borders. We heard that during COVID, and we hear it during any discussion about infectious disease preparedness and response. And it's true. Infectious disease and the other challenges facing us are borderless. But borders do still matter very deeply. The borders between states, the borders between racial, gender, class, all of those divisions that work to stratify societies domestically and globally, and that are continually working to reproduce these highly inequitable health outcomes along geographic, racial, gender, and socioeconomic lines. And how we deal with these borders, and how all of you who are about to inherit this world deal with these borders, these divisions, these tensions, that's what's going to determine whether we have a world that is shaped by the narrowest possible forms of health security, or whether it will be more shaped by a commitment to health equity and to measures that are, in the long run, what we need to prevent a repeat of the equity failures of the COVID pandemic response. And at this point, it still remains to be seen which of those outcomes we're going to see. So with that, I'm going to wrap up. Thank you again, and invite questions and discussions before we move on to your after party. Thank you. I'm happy to facilitate.
Sure.
Unless.
Do you want to hand it?
I have the whatever you envision.
All right, so questions from the crowd. I see one in the back. Let me pass you the microphone so you can record.
So I just had a quick question about like COVID-19 infection rates. I've heard a lot of people say that in Africa the infection rates were a lot lower than other parts of the world. Why do you think that is?
Yeah, so that gets to that point about surveillance systems. So part of the reason that it looks like rates were lower or are lower is that we don't have the data. we really don't have good data. Because for a lot of the continent, if you think about, for example, a place like DRC that is in the midst of some pretty persistent enduring conflict, and it is also a really huge place where you've got a lot of rural, remote areas where it's pretty hard to get out and test. That's part of it. So part of it is that those rates are most likely artificially low because we just don't have good data. But part of it also is that if you saw on the slide where I showed who in Canada was most likely to be infected with COVID and where we saw the highest rates of infection with COVID, a lot of those were in really, really densely crowded urban neighborhoods. So we did even if you look, and there's a lot of diversity in variation in the continent, but if you look at the largest cities on the African continent, that's elsewhere, you see higher rates because that's where people were in really close proximity, breathing the same air, coughing on each other, etc. But there's also in a lot of African states, especially sub-Saharan African states, you still have a fairly large population living rurally. And so living in rural areas and not congregating in, for example, really huge crowded factories, like the garment factories in Bangladesh, for example. So that's also part of it. But a lot of it really comes down to data. And the fact that we still don't have a program. Does that make sense?
I don't.
Oh, no.
Claire, your hand was up before 12 to 6 units.
Apologize, I'm asking you to repeat anything from the presentation, but the lack of preparedness, do you think that it's like in the same vein as I mentioned climate change, in that it's due to like a consciousness from decision makers that the wealthy and the elite, usually the class that they belong to, is not going to be affected in the same way as regular people, so they don't have the incentive for better preparedness?
Yeah, so I think you're definitely onto something there. So some of it might be about, a belief that if you're wealthy enough, you can go live on your super yacht or in your bubble or on Mars or wherever. So I think that's part of it. But the other piece, and the other way that this is really similar to lack of action on climate, is about timelines and time horizons. So even a really deeply committed politician or elected representative in a democratic state is focused on a time horizon that is usually about the 4 years between the time you get elected and the time you need to get reelected. So to persuade any politician to invest in something that could happen down the road, but isn't happening yet, which was the case for a pandemic, and until pretty recently seemed to be the case for climate change, it still seemed like a thing that's far off in the future, so we don't have to deal with it yet. And sometimes that's about lack of political will and not caring, but sometimes it's also just about what your electorate and what the general population wants to see. So if people are hungry now, if people are underhoused now, if people don't have jobs now, that's what they want to see action on. They don't want to see action on something hypothetical that might happen down the road, or even something that's happening now, but it's not necessarily as visible in our face all the time, which is still how a lot of people are experiencing future pandemics, even H5N1, which is a current pandemic, and it's how a lot of people are still experiencing the climate crisis as something that doesn't directly affect them immediately. So I think that's a big part of it as well.
Michael, you're gonna make me run to the back.
No, you don't have to run. I'll just yell. So hi, my name is Michael Batu. I'm an economist. I have a question. So I'm from the Philippines originally, and when COVID started, March of 2020, our country is poor, so we're not able to get vaccines right away. We got the vaccines from China, so we got Sinovac and the other Chinese vaccines. It was discovered last year through, I believe it was a Reuters report, that the United States actually caused some misinformation early in the pandemic about the efficacy of the Chinese vaccine. So the Philippines, in my view, has become a victim of some geopolitical movements between these countries. So my question for you is, given what you, as a scholar and as a person who knows this, do you think there should be mechanisms or ways in order for states to be accountable on the misinformation? Because for individuals, people were ostracized for misinformation at that time. How about states? How about countries, governments that cause misinformation and has led to deaths of people? What's your take on that? Thank you.
So just for those watching on the Zoom recording, the question was about holding states accountable for misinformation spread during the pandemic.
Yeah, I mean, that's a really good point, and especially the point about Sinovac. That also had implications because when we look at travel restrictions, a lot of countries restricted travel and restricted people from entering the country, and Canada did this too, if they had been vaccinated with Sinovac or with the Russian vaccine too. And a lot of that was down to racism, and a lot of it was, some of it was genuine not feeling that there was enough data to support the vaccine efficacy, but a lot of it was about mis and disinformation. And this again goes back to that really significant challenge of how do you hold sovereign states to account? It's really difficult to do that. I would say when we look at global governance systems, the World Trade Organization is probably the organization that has been most capable of holding states to account because it can put actual trade penalties in place. But even there, we've seen high income states choosing to just not comply with WTO rulings. So you really do have this dynamic of the higher income states, the better resource states, which in your example are the source of some of that mis and disinformation, being able to selectively adhere to or ignore global governance mechanisms, including legally binding ones and including all sorts of other aspects of international law, because they have the power to do that. And your question also just reminded me of an answer to the earlier question about the African continent and why lower rates. And that was also because in addition to the sort of deficit-focused gaps in data, those are also countries that had experienced Ebola outbreaks and Ebola pandemics. So when we look at the West African states, those are also countries that actually were pretty good at putting pandemic response measures in place very quickly right away because they had practice. So they were actually better and responded better and more quickly than some global north states that hadn't had pandemics or hadn't had sort of similar outbreaks in the past. Which again, sort of the connection that I'm making in my brain, which might not be clear to all of you, to those questions, is also about the dynamics between lower income states, global south states, and global north states, and which states are seen as having capacity, which states are seen as having greater knowledge, greater sophistication, greater understanding of medicine and science, and which ones are seen as states that are less capable. And a lot of that is deeply, I mean, if anyone has taken any sort of post-colonial IR theory, a lot of that is really deeply entrenched. Racism and mis and disinformation that is rooted in a whole long history of colonialism, including settler colonialism, and the sense that the global north and the North American and North Atlantic states are just better at doing all of these things and have greater capacity and better knowledge, which I think we saw reflected in some of those vaccine decisions and restrictions. So that was maybe a convoluted answer to that question, but I know there were a lot of other hands up. So
Okay, let's start here.
if you want to go down questions or
so if you could provide one piece of policy advice to the Canadian government in kind of along this thread of pandemic preparedness and health equity, what would it be?
That's a good one, and it is definitely get better at collecting gender disaggregated data that is not conflating gender and sex, so not slipping back and forth between male and female and men and women, and that also recognizes that there's more genders than men and women, so that we have data. And I'm thinking about that particularly in the context of COVID, because gender affirming care was deemed non-essential healthcare during COVID, so people who needed to access gender affirming care couldn't during the pandemic. We needed gender disaggregated data because people who are exposed to intimate partner violence were disproportionately gender and sexual minorities, particularly women. We didn't have that data, and we still don't have good data. And we still don't have good data about the impact of COVID restrictions on a lot of racialized populations, and we don't have good data. And some of this is for very good reason that Indigenous identity is complex and it's difficult to collect. And there's a lot of suspicion on the part of a lot of First Nations, Inuit and Métis peoples about why the government wants your Indigenous status. But without that data, we don't have an evidence base to design well-crafted evidence-based targeted interventions. So one, that is it. And two, to get better at having representatives of equity discerning populations at those senior decision-making tables, and not just like a single token seat. So two pieces.
I was wondering, as you said in the social determinants of health, I think education was one of them. And I was curious to know if the anti-vax movement has a disproportionate impact on people, like if that's another factor that can influence people disproportionately.
Do you mean according to like their education level?
Possibly if that's something that would factor in, or if it's kind of across the board, it affects people, or if it's like more pervasive.
Yeah, that's a good question. I haven't seen any good research breaking down support for anti-vax. I'm sure it exists, but I haven't seen it breaking down the extent of support for belief in anti-vax beliefs according to education level. Intuitively, it seems like it might make sense, but I think we also need to be cautious in assuming that because people have lower formal levels of education, that they care less about science and evidence and are less capable of understanding science and evidence and are less likely to take protective health measures. Right. So it's a good question. I don't know about the correlation between levels of education, but I mean, certainly across the board, we know that all of those anti-vax, the mis and disinformation impacted vaccination rates. Absolutely. And especially with new forms of social media, those can spread really quickly. So even compared to previous pandemics, when we didn't have social media and that ease and rapidity of mis and disinformation spreading, I think it's the problem is more severe and more acute now. So I think that if you did a historical comparison over time, I think that variable might be more significant than levels of education. But yeah, I don't know. It's a good question.
Laura and then Armand.
So you talked about the end of a unipolar world and moving to a more multipolar world. And like you also mentioned how it seems like we are seeing the end of liberalism. And I think with what's going on down south, it definitely feels that way right now. So how essential do you think, especially from a Canadian perspective, working with rising powers who don't necessarily align with our more Western liberal perspective is to pandemic preparedness?
That's a big question. That's a really good question, but a really big one because, I mean, we certainly are seeing rising powers and a shift to a more multipolar world. The extent to which that world is going to continue to be characterized by countries that don't share our Canadian values and beliefs, and especially that are non-democratic countries, remains to be seen. Because some of those rising powers may or may not remain authoritarian, or some current powers may slide into authoritarianism. So it's always a bit tricky to hypothesize about what's going to happen in the future. But one of the interesting things about health is that is often a place where you can find common ground, even among states and even among political actors who really significantly disagree with each other. So in the 80s, when there were these really deep entrenched guerrilla wars going on in Central America, in the context of the Cold War, so political opponents and state security forces that were very brutal and repressive, guerrilla fighters, freedom fighters, terrorists, depending on which point of view, again, you are analyzing the situation from were very, very, very deeply polarized. And in several of those conflicts, health actually served as, it's sometimes called a bridge for peace. I think it's a little bit of a hyperbole to describe what happened as peace, but there were agreements in several of those Central American countries, in Guatemala, and Nicaragua, and El Salvador, to have a suspension of hostilities, a cessation of hostilities, so that international aid workers could go in and provide routine childhood vaccinations to kids. Because all of the combatants in those really deeply entrenched and really antagonistic and quite brutal conflicts could find a common ground that we want our kids to be vaccinated. We don't want our kids dying of childhood diseases. So that gives me some hope that even if there are really antagonistic relations between states, that cooperation on some pandemic preparedness and response measures could be possible. And I think that it is essential. You asked how important it is. It's essential because this is one of those places where that whole diseases don't respect boundaries and borders is absolutely true. If there's a vaccine, if there's an outbreak anywhere and a need for vaccines anywhere, that outbreak is going to affect or potentially affect all of us, regardless of the political ideologies in the country where that outbreak starts. So you need cooperation across those partisan divides. How you get there, that's another really, really challenging political question.
With the American government taking a backseat, leaving the World Health Organization and sort of limiting their soft power on a global stage, what do you see as some of the effects of this globally, in the global south especially? And again, this is kind of adding on to the question that was asked earlier, but more specifically with China. You know, China is taking a much more proactive approach, especially with the World Health Organization.
Yeah, that's another great question. And I think that also gets back to that question about rising powers and what role rising powers are going to play in a multipolar world, and the extent to which, you know, China really is, in some important respects, stepping up and stepping into a gap that is being filled by the US, including on the African continent. And Professor Akupo is really the expert on that. But in terms so remind me of the first part of your question.
How the Americans leaving the World Health
Right. Yeah. So in terms of what impact that is having, I mean, we're already, this isn't specific to the World Health Organization, but with PEPFAR, which is the President's Emergency AIDS Relief Fund, we're seeing that funding suspended, and we already know that is going to cause deaths because antiretroviral treatments, medications that are provided particularly to pregnant people to prevent vertical transmission of HIV from mother to child, you have a limited window in which you can provide the medication that's going to prevent that vertical transmission. So we're going to see another generation of children being born HIV positive, which had been almost entirely eliminated, not entirely, but almost entirely. So that's going to cause more deaths, and obviously people not being able to access essential medications is going to cause more deaths. We're already seeing changes to how the World Food Program is structuring and organizing its operations on the African continent. They're consolidating 2 offices into 1. That's going to limit their ability, especially to get into rural, remote, and hard to reach regions. So it's not even just the World Health Organization, it's all of the other parts of the UN system. And those in some ways are actually more important, because the World Health Organization isn't a boots on the ground organization. It provides a lot of technical support, medical support, but it's the big humanitarian agencies, UNHCR, World Food Program, UNDP, UNICEF, which is really the expert on water and sanitation. So those losing funding from the United States, that's going to have a really significant impact. I mean, I don't have the exact data and stats and numbers yet, because we're watching this unfold in real time. It's predictability is not a hallmark of the Trump administration, so it's pretty difficult to anticipate some of these changes and what the impact of those changes are going to be. But I mean, millions of people are going to die is the short version. particularly in the global south, in lower income states.
You spoke a little bit about anthropocentrism. I wanted to ask you, is the suggestion that we monitor and address disease outbreaks in animal populations? And if so, can we reliably identify which diseases are likely to jump species and threaten humans? And if so, how important is this vis-a-vis increasing health equity among humans?
That's a lot of questions.
Sorry.
Those are good questions. I mean, we already are monitoring animal health outbreaks and diseases. It's just the we that is doing that is mainly animal health actors, the World Organization for Animal Health, veterinarians, et cetera. And the challenge is that we have those surveillance systems in place, but they're generally, certainly in Canada, they're not well integrated with the human health surveillance system. So the challenge is not so much that we're not collecting this information at all, but it's not being shared. And often, particularly when it comes to animals that are being farmed for food, there's a real reluctance on the part of those producers to report and to share data because there's fear about what's going to happen in terms of culling herds, in terms of the economic impact of a potential threat to human health. And there's a sense that there's not reciprocity, that even where we have diseases that could pass from human to animals, there's not necessarily the same reciprocity of proactively sharing that information with animal health actors. So better data sharing and some better integration of surveillance systems is really important. In terms of the impact on health equity, again, we're seeing that now with H5N1, because if you look at the impact on farmers, and especially smaller farmers that are having to cull their flocks, that has a really significant economic impact that is greatest on smaller farms. And I'm thinking here globally in terms of smallholder farms in the global south as well. And it has a pretty significant mental health impact. And again, even in Canada, where you see that happen in farming communities that are often more rural, that might be located in provinces that are poorer. So New Brunswick, for example, Saskatchewan, Manitoba, that don't necessarily have the same ability to provide health services, especially mental health services, to farmers and farming communities. And so when we look at rates, for example, of suicide among farmers in Canada, and also among veterinarians in Canada who are doing that culling, those are pretty high rates. It's actually veterinarians that have the highest rates of death by suicide of all professions, which is not a health equity thing, but it's just a point about the ways that animal health can impact human health in ways that we don't necessarily anticipate or expect. But you're right, that is a really big challenge, that point about how do we know which diseases to focus on. But to some extent we do. I mean, we know that bats in particular are reservoirs for a lot of the diseases that we've already seen. Outbreaks that can be transmitted to people. So we at least know which species we ought to be keeping an eye on. So we do know, but the challenge again is how do we get to a point of reliably collecting and more importantly sharing that data and information. Does that answer your question? Great.
What is the long-term incentives for states to keep up their pandemic preparedness, especially in a world with where loads of states are facing economic hardship and there are many international political tensions and potential shifts to a multipolar world? How will states keep up the incentive in the long term when many states see that as maybe a 100-year issue?
Yeah, that's a good question. And that is exactly the tension that I was referring to between that you get that sort of urgent attention to a health emergency and you have a whole lot of money and attention and resources being thrown at it, but then it recedes. And even now, when we look at what Canada is doing in terms of ramping up border surveillance around fentanyl, and when we look at the impacts of these on-again, off-again tariffs and trade war, when we look at military aid being proposed to Ukraine, there seems to be a whole lot that seems to be much more urgent right now, even for a very high-income, well-resourced state like Canada, relative to providing more funds to a pandemic fund that exists to address a hypothetical future emergency. And it's really tough to sustain that attention. There is no easy answer. And this is also why the social determinants of health are so difficult to address, because they're complex and because the impact of poor social determinants of health, the impact of a future pandemic is not as immediate and in your face. So in terms of what incentives might push or might encourage states to participate, I mean, there's some of it is you can invest a little bit, relatively small amount now, or you can invest a huge amount when we do have another pandemic. So I think there's a window of opportunity with COVID because it is still very fresh in people's minds and it is still present. So I think just using that as a reminder, rhetorical and political, and because we do have a lot of sort of hard numbers in terms of the economic impact of the pandemic. So if you want to not have another catastrophic interruption to global supply chains, not have another catastrophic shock to the economy, one way that you can do that is by investing in a pandemic fund. So that's one option, but there's a point at which you have to get states to recognize that it is in their self-interest to invest in those sorts of multilateral agreements and funds. And that is really tricky. So I have no easy answer to how we make states do that, but you're right, it's a problem or is a challenge. The one piece though that I do think is also really important, because it's easy for us to throw up our hands and say, it's impossible, all these really complex challenges, is the power of civil society. I mean, every progressive political change that has ever come about historically has come about because of civil society organizing, and because of ordinary people mobilizing in groups, mobilizing through NGOs, mobilizing through now social movements to put pressure on states to act. Whether we will see people mobilizing around a pandemic fund relative to mobilizing around the climate crisis or mobilizing around a whole lot of the other injustices we're seeing right now is an open question, but that sort of pressure can also compel states to act.
It's also a good advertisement for POSC 325 advocacy groups and social movements and politics. Other questions? Yeah, Dr. Bryce.
So I was wondering if you could speak a little bit to the challenges facing middle income countries, because you talked a lot about countries that are in the high income developed world, and you talked a lot about countries that are aid dependent, but about countries that are not necessarily dependent on some of the international aid or issues of that nature, but also are not self-sufficient in terms of being able to source their own medications or vaccines, and are not necessarily the countries that we're talking about as the, I guess, the high income countries that have the most power at the table.
Yeah, that's a really good question as well. And there's always a risk with things like a pandemic fund, that the focus is going to be on the LDCs, the least developed countries and the poorest countries of the world, and that some of those middle income, especially the lower middle income countries, are going to be left out. So that is a challenge. But the other, I don't know that this is a challenge, maybe it's an opportunity, is around some opportunities for South-South cooperation. Because I think when you look at China, India, Brazil, Mexico, those are countries that might in some respect have more limited capacity. They don't have all the resources of high income states, but they have lessons learned and they have capacity and the experience of providing health interventions in more resource constrained environments. So I think there you also have a pool of technocrats, bureaucrats, scientists, community development workers who have a much better understanding of what it means to work in a resource-constrained environment, and I think who are sometimes more likely to be able to come up with policies and programs, and especially that implementation piece, that are going to work well in lower income states. So I think those opportunities for South-South cooperation. If we consider countries like China and India and Brazil still south, but those opportunities, I think, I think there is really an opportunity there. Because we do sometimes see, with the best of intentions, folks in higher income countries who have never set foot in a global south state coming up with what look on paper like really good policies and programs, interventions, but they don't have the on the ground experience. So I do think there's an opportunity there as well, which again speaks to who's at decision-making tables and what is the composition of those tables. And that's an area where, because the WHO is organized into regions, you've got, I think, compared to some other parts of the UN system, you actually have better opportunities there because you've got a region for the Americas where you could see some of those middle income states take on a leadership role more easily than in some other parts of the UN system where great power politics tend to dominate negotiations. So I think there's some opportunity there as well as some of the risk of some of those states falling between the cracks.
All right, Dr. Hugo.
Yes, thank you very much for the talk. I have a quick question regarding usually our minds are on modern health systems. So given the fact that some of these developing countries lack those modern health systems, but they have traditional health systems which they use to survive in periods like that's the fact. Part of the argument is that on the African continent, for example, without the vaccines, they try to use traditional health, intervention, systems to try to weather through the pandemic. To what extent do you think that should be a priority? For example, the World Health Organization to help to bolster health equity, for example.
So you mean in terms of better integrated?
That's right.
Yeah, it's a huge, and this also speaks to some considerations around indigeneity and indigenization of health systems. So I do think it's really important, and it is something that at the UN Permanent Forum on Indigenous issues, there's been a lot of movement and mobilization around because part of that is about how we think about health in the global north, and in North America and Western Europe, we have illness management systems. We don't have health systems. So because we have a particular conception and very biomedical approach to health, and a lot of other communities, cultures in the world, a lot of indigenous communities, and as you've alluded to, not just on the African continent, but elsewhere, Southeast Asia, like India has a very long tradition of a lot of what gets lost is traditional medicine, same thing with traditional Chinese medicine, that is much more holistic and is much more about well-being and about approaching health as being about being in balance, and also being in balance and in relation with land and with more than human life and with understanding more than human life as relations. So yes, it is absolutely we need to be careful not to have this sort of romanticized, well, those other people in places can just use their traditional healing and traditional medicines, and they don't need modern vaccines, and they don't need the top tier modern science. So we do need to be a little bit careful to recognize that, yes, but vaccines are also still very important. But I do think it is really important to think more expansively about health and about health supporting interventions. How that happens, again, part of it is about who's at senior decision-making tables and who is represented in terms of civil society, in terms of indigenous organizations, in terms of NGOs that represent equity deserving groups. And some of it also is about what sort of capacity is required to allow people to practice traditional medicines or engage in traditional, more, it gets lost as traditional healing. And again, thinking about the Indigenous case and reconciliation in Canada, that can be things like, on our campus, we've got smudge-friendly spaces on campus. So that's not directly about obviously smudging is not going to have an impact on COVID, but it's about social support and inclusion, and again, about recognizing that mental and spiritual well-being is an important part of physical well-being. So that's a really small local example, but thinking about how you scale that up to how entire health systems are organized, it's a really important problem and challenge and puzzle. So this is a very long-winded way of saying, yes, you're absolutely correct. It is absolutely important. And if you have insights into how we might do that better and support it, including through things like the pandemic fund, I'm sure that your expertise would be valuable.
All right, in a moment, I'm going to turn things over to our dean, Dr. Sylvie Murray, for closing remarks, but I want to use my microphone prerogative to ask one last question. And that's, I think, a lot of the issues that we've raised today and a lot of the news cycle today, we're seeing a lot of fear and sort of doom and gloom in the world. So what's something, when you look at global health systems today, and maybe the pandemic response, what's something that gives you hope or leaves you with maybe a positive feeling of where we could be moving?
That's a really good question. And I'm going to fudge a little bit and not talk about the COVID response specifically, but I'm going to talk about the global response to HIV and AIDS, because that is where I began researching before my trajectory sort of shifted. And that, I think, is a really excellent example of an absolutely transformative response. So again, talking about the power of civil society and civil society activism, we have effective AIDS treatment now because a whole lot of people, members of equity deserving groups, particularly queer communities, but also in the global south and on the African continent in particular, the Treatment Action Campaign in South Africa sort of always held up as a paragon, an example of effective civil society organizing. Those people got really mad that they were dying. They were watching entire communities and entire populations die, and the majority of the world didn't care and wasn't paying attention. And it seemed like a fist was being driven through generations, and that people were dying. There was no hope. There was no treatment. AIDS was a death sentence. And so people got angry, they got mobilized, and they held political leaders to account, and they held pharmaceutical companies to account, and they held pharmaceutical companies to account in the context of trade-related patent agreements, and they held large corporations to account. And that was very difficult work. It took a lot of time and a lot of organizing, but because of that, we saw a transformation and a massive reduction in global rates of HIV and AIDS. We also saw a whole lot of other human rights advances that came along with that. And at UNAIDS, we saw the creation of what in the UN system is in some ways a unique organization, because it really took up that ethos of nothing about us without us and ensured really significant, robust, substantive representation of the populations and communities that are most affected by HIV. So that's where I look to in terms of transformative responses that give me hope that we did that once, we can do it again.
Thank you. I think it's a great place to end on. I want to turn things over to our dean, Dr. Sylvie Murray, for some closing remarks.
Thank you so much. I really appreciate the closing note on a hopeful outlook on these complex interacting systems. So thank you, Noah, for the question and for your historical reminder there that we've been through pretty complex situations in the past, and civil society has been so key, and individuals being willing and able to step up for their communities and defining their communities in generous ways. So that is hopeful. So I want to just maybe go back to the opening where we reminded ourselves of working on Stalo territory, and there's a Stalo practice of witnessing that I like to call when we are at the end of an event, which is that we are all witnesses to a lot of learning, and our responsibility is to share that to those who were not able to attend today. So I think that's a way of paying respect to our to somebody, a learned scholar who shared so much information as well as spread the word in a way that's true to our own values and our own truths. But I think it's really important to talk about these complex situations. And, you know, I have a lot of notes and scribbles and circles and squares about what stands out. You know, the kind of interaction of complex systems is very striking and it can be very discouraging. But again, that focus on the power of civil society, how we define communities, how we decide to engage personally in those discussions, I think is so critical. So thank you so much for very informative and challenging, and thank you so much to all of you. I always so much enjoy coming here and seeing the engagement and the amazing questions, the difficult questions that you're bringing to the conversation. So thank you to my colleagues for organizing this as well. So thank you.
And we also have a small gift from our department. I don't know, maybe we should be on the camera.
Yes.
Yes. All right. Let's work for the camera.
Thank you, all of you, for all these really excellent questions and for staying for so long at the end of a long day. This was a really excellent conversation. Thank you.
Make sure to grab as many pizza or as much pizza and snacks as possible. We don't want to take anything home, so eat it all.